Safe and effective means the benefits outweigh the risks for most patients. That's probably not how most of us think about safe and effective, but that is the definition for FDA. So keep in mind that it's okay if most patients don't benefit from a drug. So for example, many cancer drugs don't work on most patients. They work on maybe a third of the patients or something like that. But as long as they're not terribly harmful to most patients, then that risk-benefit ratio will still be considered reasonable. And also to be sure that you understand that the FDA by law cannot consider cost. So the FDA knows that when a new drug is approved, it's probably going to cost more than the other drugs on the market, and it's especially going to cost more than generic drugs. But that FDA cannot consider cost, so they do in fact approve a new drug knowing it might not be as good as an older drug that costs 10% as much or something. These are the things that it doesn't mean. FDA approval of drugs or devices. It does not ever mean that nobody will die from this product. It never means that. It doesn't ever mean that few people will be harmed by this product. It could be that people will be harmed by the product. Again, it's a ratio of benefit to risk. It doesn't mean that the product is safe for long-term use. Almost all the time, FDA requires studies that are relatively short-term. Even if the study might be 2 years, it might be for a cholesterol-lowering medication or a pain medication that might be used for many years. So it's pretty much never true that a product is going to be studied for as long a period of time as people are going to end up taking it. And as I just alluded to, FDA approval never means that this is proven more effective than any other product on the market or cheaper products on the market. Sometimes they are more effective, but that's not the standard that FDA has. By law, that is not the standard. Clinical trials are important. Clinical trials are studies of humans, which are used to prove, in the case that we're talking about, used to prove whether product is safe and effective. And as we think about what are the outcomes that matter to you, and I'm happy to add a few to this list, and obviously it depends on what the illness is. So it might be survival, especially for something like cancer or heart disease. It could mean fewer days in the hospital for the next year or maybe several years. It could mean fewer serious or unpleasant side effects. So a side effect can be very serious, can be deadly. But if you're nauseous all the time, that's not serious, but it's so unpleasant that it just might be unacceptable anyway. And then other symptoms that can result from devices or from drugs, such as pain, such as nausea, and any other ones that people want to mention? Constipation, that's a good one. I guess diarrhea being the other. Any other that people, Mary Ellen? Fatigue. Fatigue is a very good one. Okay. So again, randomized double-blind clinical trials. That's the gold standard for the FDA and in medicine generally. So remember that in a randomized double-blind clinical trial, patients will be randomly assigned to either be in one group or another. It might be drug 1 versus drug 2, it might be one drug versus placebo. Obviously it can be a device too, but talking about drugs here. And what makes it double-blind is that, number one, the patient doesn't know which drug they're on, whether they're on the drug or the placebo or drug number 1 versus drug number 2, and the doctor or the researcher also doesn't know. So that's what makes it blind. It is blind because nobody knows except somebody behind the curtain who is not directly involved in the study, is not evaluating how well people are doing. And that's a way of getting rid of that bias. And again, the main focus for drug approval is that it's safe, but that's safe, but usually based on 2 short-term clinical trials, and that it's effective, usually, although not always, compared to placebo, or in the case where it would be unethical to compare it to placebo. So for example, for cancer drugs, you might have the new cancer drug plus the old cancer drug compared to the old cancer drug plus placebo. So nobody's getting nothing, but you're still comparing it to placebo. It's just a combination. Yes? Oops.
Are the 2 short-term clinical Are the 2 short-term clinical trials, is the second one a replication exactly of what the hypothesis is in the first?
Yeah.
Or can they alter them at all?
They can be altered, but they should have some similarities that of outcomes and so on. But it could be different population, you know, it could be somewhat different in terms of size. It might start with a small one, then have a larger one, for example. Now, the big push on the FDA now is to speed up the process. There's a lot of desire to get new products on the market more quickly, and FDA is in fact getting products on the market more quickly than other countries and more quickly than they ever did before. And there are various what are called pathways at the FDA to do that. They have different names, but they're basically geared towards getting that FDA approval, or at least an FDA decision, whether it's an approval or not, getting it more quickly. And as a result of that, a lot of drugs now are only studied based on 1 study instead of 2. But in science, in all of science, not just medical science, but in all of science, science is based on replication. Scientists believe that you don't know if something's true until it's been replicated. So if you only have 1 study, maybe that study's correct, and maybe anytime you replicate it, you'll get the same result, or maybe you won't. And in fact, there has been an article in a scientific journal pretty recently saying how rarely studies are replicated when scientists try to replicate them. But the other part about science is that, again, there's a lot of pressure to be the first. You want to do the new study on the new idea, and you don't want to be the second person studying it. And there might not be money to be the second person studying it. And there's not as much fame to be the second person studying it. It might be hard to publish in a medical journal or any other journal if all you're doing is replicating. So there's a lot of desire among scientists to be the first and less incentive to be the one replicating. Yeah, John?
Yeah, forgive me if you're going to cover this, but there's also a move now to reinterpret the data from an initial study. And that's gained quite a bit of traction based on what I've seen.
Okay, well, we'll talk, yeah, we can talk more about that later. So just as a few examples, and another way that, that the studies can be done faster is to look at surrogate endpoints. And Helen mentioned this, and I think all of you have at least heard the term before from the intro workshop or from other reading. So biomarkers or surrogate endpoints are things that you measure that aren't really your health. So we think of lower cholesterol as being our health, but actually it's more of a, what might be called a marker or a surrogate for health. So same with glucose levels, same with bone mineral density, same with progression-free survival in cancer. I'll give you some examples of this. So a drug can lower glucose, sugar levels, but still not help diabetics live longer or healthier. That has happened. Or you can have a drug that's really good at lowering blood pressure, but somehow the patient's lives are not being saved. Or you can have a screening test to prevent death from cancer, but the patient won't necessarily live longer. And that's, for example, x-rays for Lung cancer is a good example of that, that people get x-rays, used to get x-rays for lung cancer, and they could get a detection of lung cancer earlier, but by the time it was large enough to show up on that x-ray, it was too late to do a successful treatment or surgery. Similarly, chemotherapy can kill cancer cells, and if the surrogate endpoint is shrinking a tumor, then it looks like it's working, but it doesn't necessarily help the person live longer, and it can make their life miserable. So the key question for all of you as patient advocates, as you think about research, is do you want biomarkers or surrogate endpoints to be used in research? If they are used, what kind of protections do you want? What kind of safeguards do you want to make sure that those surrogates really will predict a healthy outcome, and making sure that research is done about healthy outcomes, not just about these surrogates. So again, I'll just go to the example of cancer, which is of concern to many of us, even if we haven't had it ourselves, because who doesn't have a loved one or a friend who's had cancer. 2/3 of all cancer drugs in recent years are now approved on the basis of surrogate endpoints, and that surrogate endpoint is usually going to be shrinking a tumor. And then the FDA will require what they call a post-market study. All a post-market study means is it's a study done after it's already on the market. In other words, it's already approved, it's already being sold, and now it's being studied some more. That's what a post-market study means. For the FDA, they'll say, we're going to approve this cancer drug on the basis of the fact that it shrinks tumors, but now you have to do a longer-term study. It will take longer to do, usually a few years longer, to see, so you can shrink a tumor in 5 months or 3 months, but you might have to study it for a couple of years to find out if people actually live longer. So the FDA will say, you have to prove that your product will help people live longer. And then the FDA will give a few years to the company to do those post-market studies. And what some researchers have found is that most of these cancer drugs, of these 2/3 cancer drugs that were approved on the basis of surrogate endpoints ending in about 2012, so we now have a few more years to have done additional research and to look at it, most of them have not yet, and perhaps never will be, proven to prolong life. And our center has done some research also showing that they're not necessarily improving quality of life either. If you look at the post-market studies, there's no evidence that these cancer drugs are really having a benefit. And by the way, they cost over $100,000 a year. Now, these ladies will look familiar from the ad that we just looked at. This is what it says on the website, the company website for Farxiga. It removed some blood sugar, some emphasis, that's from me. It significantly lowered A1C. For those of you who don't know what that means, it's a credible surrogate endpoint. And it says, additionally, Farxiga may help you lose weight, on average 3%. Well, 3% is not a lot, although most of us would be very happy to lose 3% weight. But you see there's a couple of asterisks after that. I don't remember exactly what it shows on the website, but in the study that was done, that was provided to the FDA and has now been published, basically what they said was they did lose weight, but so did the placebo group, because both the placebo group and the Farxiga group both had some kind of diet and exercise plan. Now, we all know we don't, just because we have one doesn't mean we follow it, but in this case, yes, they did lose weight with diet and exercise, and if they took nothing, they'd also lose weight with that same diet and exercise. The other thing to know about Farxiga for diabetes is that there is no evidence one way or the other, whether people taking it live longer or better, have fewer amputations or any of the other things that plague people with diabetes. And these are the risks that might not have been quite so clear in the ad. And these are the ones that FDA established with the company's own data. It can cause kidney damage. It definitely increases the risk of urinary or genital tract infections, particularly on women, but on men or women. What they don't tell you at all in the ad, but was found in the study, was that patients were 5 times more likely to be diagnosed with bladder cancer. That was not mentioned in the ad. Instead, what the ad says is, don't take it if you have bladder cancer. Well, that's nice. But what the study indicated was that people who didn't know they had bladder cancer were more likely to get bladder cancer after taking this drug. 5 times more likely. Now, again, let me speak fair, it's still 1% or something. So it's not a high risk, but it was a much higher risk than they would have otherwise. And there was also some question about whether it might increase the risk of breast cancer. Those studies were done on rats, and the FDA has not required a post-market study to look at that. So again, we're talking about post-market studies. What's the difference between pre-market studies and post-market studies? When pre-market studies don't provide evidence of living longer or better, then FDA usually will require a longer-term post-market study in order to gather more information. But think of it this way. The product's already on the market. People are already paying for it. So as a patient, if you're taking the drug, whether you're in a post-market study or not, you're basically paying, sometimes a lot of money, such as in the cancer drugs, paying to be a guinea pig in an experiment for a product that isn't proven yet. And the other part of this that I find particularly disturbing is that the company has so little incentive to do that study quickly, to do it well, to include a diverse group of patients. So the FDA might say, well, you don't have enough women in this study, or you don't have enough people over 65, or you don't have enough people of color. So we want to make sure that when you do your post-market study, you have more of those different groups. But there's nothing that requires them to do that. They're only saying, we'd like you to do it, and sometimes they do it, and sometimes they don't. Helen?
Do they require that they report the results of these studies?
When they require a post-market study, the company does have to provide the results of the study to the FDA. It is not required to be published. Once the study is finished, if the company is still advertising it, then the information from that study should influence what's in the ads. Does anybody ever check to see if that's true? I couldn't tell you.
Is it publicly available if they report it to the FDA?
It should be on clinicaltrials.gov. Some of you know that this is a website, and we'll be talking more about it. I think that's tomorrow, or whenever we're going to be talking about clinicaltrials.gov at this workshop. But the thing with clinicaltrials.gov is that companies and other researchers are quite good at including information about a new study on clinicaltrials.gov. They're incredibly bad about reporting the results of the study. And that even though they're required by law to report the results of the study, they're required by law to report it within a year, and most haven't reported it within 5 years. That's how behind they are. Mary Ellen?
What are the parameters for the post-market studies? Do they go to the doctors and ask the doctors to do studies on their patients? And are the patients notified that they're in a study? How does that work?
Yeah, well, it'll vary according to, basically the company will design a study, the FDA has to approve it. The study can be the same patients. For example, if a company has studied 200 patients for 6 months, they might be told to continue with those same 200 patients for the next 3 years, just as an example. Or it can be completely different. They can start all over again with a new group of patients. But anytime patients are in a study, the patients have to be notified that they're in the study. You can't just study them without telling them. Kim?
Are these observational studies, or are they controlled? Because if it's that same 200 patients, is it still against placebo, or are we just now looking purely for safety?
Yeah.
And then are there really, like, when it is an observational, like, can't you just, anybody can decide what the observation is going to be, right?
Right.
So if you don't have that control to it?
Yeah, it really varies. Again, often these post-market studies are clinical trials. Not always, but often they are. As you say, observational studies are very hard to do, so you'd have to have a really good design. On the other hand, you might need to do an observational study, especially if a product is perceived to be so effective that it would be unethical to randomly assign people to placebo and not get this new drug. Or even if it wasn't unethical, that maybe you would find that no patients want to sign up for it. So that's one of the shortcomings of post-market studies. I talked about the lack of incentive for companies to do it, but there's also a lack of incentive for patients to participate. If you think that this new drug for whatever disease ails you is better, you've seen it advertised on TV, your doctor's heard about it, if you think this is a great new drug, who wants to be in a clinical trial where you might get the drug or you might not get the drug? And with post-market studies, whereas a pre-market study, almost always the patient doesn't pay for the medication, but in a post-market study, sometimes they do. So, who wants to be in a placebo-controlled trial if you might end up getting nothing? I mean, I'm sure there's some way that they work that out, but still, for patients, you could see that when drugs have a lot of hype around them, whether the hype's deserved or not. When a drug is seen as really great, everybody wants it and nobody wants to be in a post-market clinical trial where they might not get it. Kim?
I know this is jumping way ahead and everything, but in my experience with a lot of things is, and I'm being a little bit of the devil's advocate here, is that the doctors aren't informing us of the risk of a lot of the products either. How do we get this information? And it's, the studies aren't being done, and we all know this now because we've been through it, but I'm having a hard time. How do we get this information? I can't rely on doctors, from what I've discovered, to tell me what's going on with all the risks and side effects,
Well, you're absolutely right, and that is a very important problem. I mean, one of the things when Tracy and I have been looking at these cancer drugs, the ones that do not have any benefit that we can tell, but are still on the market, who are the doctors prescribing these drugs? We don't for a second think any doctor's prescribing them knowing that they're not effective. They're prescribing them because these drugs were approved by the FDA as a breakthrough drug, and they don't understand that in FDA lingo, breakthrough means promising new drug. It doesn't mean proven effective new drug. And so there's certain hype with the terms that are used. Some of these drugs do have articles that have been published in medical journals afterwards saying this is the post-market study and there's no survival benefit in terms of these cancer drugs. But most of them just have no publications at all. Because let's face it, if the company is paying for a drug study, they're not in any big hurry to publish an article showing that their product that's still on the market and costs over $100,000 a year doesn't actually work. So you ask a key question and there's no simple answer. Patients should ask, but ask their doctors, what is the actual evidence? But don't be surprised if the doctor doesn't really know, because doctors can't read every new article, and in some cases with these post-market studies, it's not public anywhere. It's not published. It's not in clinicaltrials.gov. It isn't being presented at medical conferences. There's no way to know. Yanli?
At several our FDA committee meetings, a number of our members, including me, realized that the post-market studies, it is not there really to really track the risk after the drug is approval. If you really want to make sure as a federal agency the drug is safe to the population, you put a gate in there, you know, really guard the gate. But a lot of members still approve the drug because they said, even though they think they don't trust the post-market, they don't think it's good enough, they still say, oh, let a post-market study to do the job. My question is, were you gonna talk about how we as a public patients advocate could help make this, you know, post-market studies really a true post-market surveillance for the safety for the public?
I wish there was a simple answer to that question of how to make sure that the post-market studies are done and are done well. I think one of the things that patient advocates can and should do is talk to FDA and their members of Congress about legislation that has been introduced in the past and is being introduced now that really pushes the evidence into post-market studies instead of pre-market studies. For decades, the FDA has required products to be proven safe and effective before they can go on the market. Part of this push to make things faster is a push to say, as long as the pre-market studies show that it's not killing people immediately, and as long as it's promising that it looks like it could help them based on surrogate markers or something like that, then that's good enough. And I think most of the people in this room, you know, or at least many of the people in this room, don't think that's true. They want better evidence at the beginning. Now, if you have a deadly disease and you're going to die anyway because there's no treatment, you might feel differently. You might say, I'm willing to take that risk, speed this through because maybe it will help me and I have nothing to lose. And we'll talk more about clinical trials later and experimental drugs later and that kind of thing because, of course, you might think you have nothing to lose because you've got 6 months to live, but that doesn't mean you want to die tomorrow. So, or it doesn't mean that you want to spend your last 6 months having had a stroke that paralyzes you. You know, you're taking a cancer drug that has resulted in a stroke, like Avastin. That was one of the side effects of that drug. So let's go through the criteria for device approvals, which by law are different than for drugs. So drugs have to be safe and effective, and we talked about what that means, benefits outweighing the risks. Devices have to be reasonably safe and reasonably effective. Again, similar, you know, the benefits should outweigh the risks for most people, but it's a little unclear, but clearly seems to be saying the standards are lower, reasonably safe, reasonably effective. Let's talk about what that means. More than 95% of medical devices are not required to be studied in clinical trials. The FDA does not require clinical trials at all for over 95%. And that includes hips, hip replacements, knee replacements, shoulder replacements, most of those joints. Actually, a fair number of cardiac implants don't have to be studied in clinical trials. Many, a really kind of shocking number of devices don't have to be studied. Let's look at that visually. The lowest risk devices are not tested at all in any way, shape, or form. And those include things that you might say, okay, fine, Band-Aids, tongue depressors, crutches. I like the example of crutches because, you know, that's a low-risk product unless it doesn't work. You know, if you've got crutches that break when you try to walk with them and you fall down, you can be really hurt by that, permanently hurt by that. So even a low-risk device has some risks, but the feeling is any reasonable company will know how to make these devices, and FDA does not ask them to submit anything about their product. The moderate risk devices, which is a huge percentage of devices and includes a lot of different things. So here you have a hip replacement graphic in the middle. You have the inferior vena cava filter, which is a filter that's implanted in the body to filter out blood clots. That seems very high risk, but they call that moderate risk because it's supposed to be temporary. You have a glucose meter to measure blood sugar. Again, that might seem moderate risk unless it's inaccurate, in which case it could be fatal or very, very harmful if it's so inaccurate. And then contact lenses and contact lens solution. Contact lenses are devices, and contact lens solution are also considered devices. These are moderate risk devices. None of these products studied in clinical trials unless the company wants to. The FDA doesn't require it. And about 98% of devices that are on the market with some kind of regulatory activity by the FDA, some kind of FDA review, are these moderate risk devices. They're reviewed through something called the 510K process. That just refers to a section of the law that happens to be numbered 510K. They're not tested for safety or effectiveness, but instead these products must be substantially equivalent to some other devices that are legally on the market. So there are no clinical trials required except under very rare circumstances. No inspections of the manufacturing facility to make sure it's being made the way they're supposed to be made. And prior to selling it, they might have inspections later if there's a problem, but not before they're sold. And again, by law, the FDA cannot require post-market studies when they first clear these. It's not called approval. When they first say, yes, you can sell these hip replacements, it would be logical if there's no clinical trials to say, yes, you can sell them, but we'd like to see clinical trials. By law, they can't do that. So that's part of the beauty of this process, is that they have to be substantially equivalent to another device that's already on the market, which itself was never had to be proven safe or effective in clinical trials, because it's a little bit complicated, but the law was started in 1976, and the new products were supposed to be substantially equivalent to something that was already on the market before 1976. It's called a predicate device in this case. And the ones before 1976 had never been tested at all because the FDA had no jurisdiction over devices before 1976. I think the original intent was that as more and more devices changed and got more sophisticated, those earlier devices would no longer be sold, but instead they've just had a train, if you will, of devices. So, let's say you had an implant that was on the market in 1976, and then in 1980 the company changed it, but they said it was substantially equivalent. And then 5 years later they changed it again, but now it's substantially equivalent to the one that was cleared 5 years earlier, and it just keeps going. So and I'll show you some pictures that will illustrate that. Actually, that's the best way to show it. Yeah, Cindy.
Thank you. I just want to say that the clinicaltrials.gov is an excellent resource, and I found my Reveal, it was a Medtronic Reveal XT implantable loop recorder placed into my chest, and since 2008, when the device came out, and it's now 2016. I'm looking at it right now on my computer. No study results posted. That's 8 years. So if you have something that you want to look up and see if there's any studies, that's a great resource to use to find that out.
Well, let me say that unfortunately the fact that it says that doesn't mean that there is no studies. It just means that they haven't been submitted to clinicaltrials.gov. I mean, it might well mean that there's no studies showing that this is a good product, because of course when it's a good product, then the company wants everybody to know about it. But you can't, I mean, that's one of the problems with clinicaltrials.gov. You can't assume just because nothing's there that nothing's been done. It might mean that, or it might not mean that.
I've done further research. I
Yeah.
haven't done anything yet,
Yeah.
but
Well,
I'm
as
sure
I
I
said,
haven't
it
reached
could mean that, but you can't assume it for everything. So let's talk about those 2% of medical devices that are considered high risk by the FDA. The middle one is a pacemaker. You might be surprised to know that this silver shiny thing is an artificial heart. And this other thing is an infusion pump, something that would be used in many, many hospitals. These are clearly life-saving devices, but of course they're not the only life-saving devices, but these are clearly very high-risk life-saving devices. They go through a process called the pre-market approval process, or the PMA. The women from Essure are probably surprised. It's a little weird that the Essure birth control device was also considered the highest risk. Why? I think the answer to that is probably more history than anything else, that because IUDs and were found to be very dangerous after women had them for a long time, that reproductive devices ended up with more scrutiny. As we'll talk about later, not very good scrutiny though. So highest risk devices tend to be implants, although many implants are not high risk. They tend to be life-saving, although many life-saving devices are not considered high risk, or life-sustaining. Again, many are not high risk, but some of them are. And they go through a process that's more like the drug process of clinical trials. They must be proven reasonably safe and reasonably effective. Remember, those other devices didn't actually have to be proven to be safe or effective. They only had to be substantially equivalent to a device that was assumed to be safe and effective because it's on the market, but was not proven safe or effective either. So what's different though about devices is, remember I said that traditionally drugs are studied in 2 clinical trials. For devices, it only is 1. And although many drugs are only studied in 1, at least some are studied in 2. All of these device approvals are based on basically 1 clinical trial, almost never double blind. In fact, often not single blind, and almost always a smaller sample. I mean, you have sometimes thousands of patients studied in a drug study, and you might have 40 patients in a device study or 100 patients. It's not unusual at all. So even for these very high-risk devices, they're not being studied on very many people. So a typical device clinical trial might be a controlled but not a random clinical trial. That would be one where the doctors or the patients choose who gets which device, and where they compare the patients receiving the new device with patients who don't. Especially when you have an implant, you can imagine it would be questionable to have surgery and not put anything in. So, there are reasons why double-blind studies are very uncommon for devices, especially for implants. So instead of having it randomized, you might have 2 patient groups that are similar or that are matched, in terms of age or sex or diagnosis or hopefully all of those things. So that would be a more typical device trial. Not as good as the gold standard of a double-blind randomized clinical trial. But it's also not unusual to have clinical trials with no control group. And eSure is such a good example of that, but not the only example of that. So that's the eSure device in the photo. The patients or the doctors, or both, chose or will choose who gets the new device. And sometimes it's not compared to anything, or it's compared to some kind of general information about women that age in general, or people that age in general, or something like that. So in a study like this with no control group, all we can tell from the study is how the patients feel. In the case of eSure, did they get pregnant or not? What symptoms did they have? But we don't have anything to compare it to. And that's a real problem. You want to have that control group. You want to be able to compare them to other people who are just like them, but who didn't get that product, in order to say what's the benefit and what's the bad side effects of that product. So then the question might come up, well, is an uncontrolled clinical trial better than no trial at all? And I would say, this is my opinion, if researchers are looking for the truth, then any clinical trial can be helpful, even a badly designed one, if they're looking for the truth. But if the goal is just to prove that their product is safe and effective, and that's really what they want to do, it's a lot easier to do that when you have no control group. And again, I can use the eSure for a good example. You had women coming in saying, I have terrible, terrible pelvic pain. And you had the doctors saying, well, we're not even going to count that because that's not related to the device. How did they know it wasn't related to the device? They just assumed it wasn't related to the device. In some cases, they said, talk to any OBGYN, and any OBGYN will tell you that a lot of women have pelvic pain. The main reason why women go to OBGYNs is because they have pelvic pain. Well, that may or may not be true, but that's still not women in general. So, in my opinion, you always want a control group. And if you had controlled the women, had a control group comparing the women getting eSure with women using some other kind of birth control, whether it was an IUD or anything else, then you would have been able to say they were more likely or less likely to have pelvic pain, they were more likely or less likely to get pregnant, they were more likely or less likely to have any number of other side effects, that it was just easier without a control group to say, oh, that's unrelated. That has nothing to do with it. So, picture's worth 1,000 words. Here's some of the things that FDA thinks are substantially equivalent. These were two types of jaw implant materials. One of them looks like something that you would fix your furniture with, and the other is a sheet of silicone, kind of a mesh. And as you can see, they don't look anything alike. They're made out of completely different material. How anybody could think these are substantially equivalent, I could not say, but FDA did. And by the way, these metal implants did end up doing horrible harm to patients who ended up, in some cases, with holes in their skull and unable to eat anything but liquid nourishment because they could no longer, they no longer had a jaw that was functional. Here's another device that's a little harder to see, but this was a temporary implant for also for the jaw area. You can see one of them is a small piece. The other one goes all the way around the jaw. One has movable parts, one doesn't. Again, how this could be considered substantially equivalent, it takes a lot of imagination, I think. And here's a spinal system. You might wonder why spinal surgery so rarely works. Here's, one device, again, looks like some little screw thing that you would put in your furniture. The other is that metal coming up from the spine, so here. And obviously this has little resemblance to the other. One has moving parts, much more complex. It's changed dramatically since 1996, and yet it's still substantially equivalent. and being cleared that way. And the last example is a non-thermal shortwave device for pain. The early one, you can see the person is actually in it. Now it's just put on the limb or whatever is in pain. So again, really different. And yet, considered substantially equivalent. By the way, no evidence that either the old one or the new one actually works, but both were cleared. And some of you have seen this photo before. In 1 year that we were studying, almost 500 million devices that had gone through this 510K substantial equivalence review were recalled later by the FDA as being high risk, more than 500 million in 1 year, including the contaminated alcohol swabs that killed this little boy. So, in conclusion, and then I can answer any questions. Remember, the gold standard, 2 double-blind randomized clinical trials that actually study patients' health, whether the health is survival or pain or something that really matters to patients. Unfortunately, today's FDA, partly because of laws that have changed and partly because of pressure, rarely requires 2 double-blind randomized clinical trials that actually study patients' health. And they especially don't require that for fast-track drugs, but sometimes they don't require it for other drugs as well. And they never, ever require 2 double-blind randomized clinical trials for devices, never. More than 95% of medical devices have no clinical trials or proof of safety or efficacy. Just not required. If the company's doing those studies, we don't know about them. And then to get back to the first thing we did today, the ads that you'll see for these products are selling hope, but are not giving you the facts based on the actual studies that have been done. So what are the implications for this? As we talked about before, whether you as a patient advocate care more about the speed of approval of new treatments, or whether you care more about good safety data or good data showing something works. I mean, we talk a lot about safety, and many patients, advocates care a lot about safety, but it's obviously hugely upsetting if you find out that your product is perfect, that your medical product is perfectly safe. It just doesn't work. So whichever you care about more is probably going to be dependent on the options you have. If you're desperate for a treatment that works and nothing has worked, either there's no treatment or you've tried everything already and you're willing to take a risk, then you wish that FDA would move things along faster. But, you know, if you're taking birth control pills and there's 80 different kinds, wouldn't you rather take the ones that are safer? Or if you're, you know, taking heart disease medication, wouldn't you like to take the medication that's safer for you? And wouldn't you like to have good evidence to know what that is? So desperate patients may choose riskier treatments, and they may even be willing to pay for ones that aren't proven. And that is part of the big debate right now about what should the standards be. And that's exactly why FDA is saying we need to talk to patients about this. And we'll talk more today and tomorrow about that. But what's happened is that so many patient advocates are getting information from their doctors and or drug companies about the need for faster approvals, and they're not getting the information about safety. Mary Ellen.
I was just wondering what the current state of play really is for patients or for doctors to be required to communicate some of this information. I know that doctors vary in what they communicate, but is there any legislation or any regulations that are moving forward in that direction?
In terms of doctors, you're asking, are are doctors required to give safety information and effectiveness information to
Yes.
patients?
In terms
Yeah.
of, I know that they do get information flowed to them from the FDA, from the CDC,
Yeah.
that sort of thing. And what are the requirements? First, I understand
Yeah,
doctors
sure.
have varying opinions of the requirements.
Sure.
And they have varying implementation of those requirements. But what are the basic requirements, and is that changing?
Well, the FDA has a very clear limit, and they will say to you, we do not interfere with the practice of medicine. We do not tell doctors what to do, and we do not tell doctors how to prescribe. And if a doctor wants to prescribe a cancer medication for arthritis, he or she can do that. Now, they might get sued if the patient is harmed, and there's no evidence that this would have worked and this was a stupid idea. But the FDA, there are some restrictions, and opioids actually is a good example where more and more the FDA is trying very hard to restrict bad practice. But there's a real limit to what the FDA feels that they can do, and a real concern about things like getting sued, the company suing because of free speech issues, which gets back to the advertising thing too. It's listed as a free speech. Why don't I just go through it? I have one more slide after this, and then we'll open the whole thing up. So, as I've said, unproven treatments can mean a shorter life, not necessarily, it isn't just that they may not work and you may not live longer. They may harm you and you may live a shorter period of time. And it can include worse quality of life. Some of you know with Avastin is always my example of that women with stage 4 breast cancer took a drug that they thought was going to help them live longer, and there was a dramatic increase in stroke. And so you ended up with women dying of breast cancer while paralyzed. And again, implications, good quality research does take time. You can speed things up, but if you really want good quality research that's going to prove what's likely to happen, it takes years to do, and it takes time if you're going to replicate it, if you're going to do 2 studies. Now, you can do 2 studies at the same time, but companies, very often like to do 1 study at a time because they don't want to waste their money if the first study isn't going to have good results. So that's part of why it takes longer. Meantime, while, if we keep our standards high, if we keep those scientific research standards high, some patients are going to die waiting. They're going to die waiting for a new treatment to be approved. On the other hand, some patients are going to be harmed, the way things are now, by an unproven treatment that has been approved. And that's not even counting the people who are harmed or helped by experimental trials. And again, just to remember that new isn't always better. New medical products may be better or they may be worse. That's why we do studies. We don't know. They may be promising, they may look great. By the time you get to these major clinical trials, there have been some studies that make it seem promising, but there are a lot of drugs and devices that never get through that to the finish line because they start out looking very promising, but somewhere along the line you figure out that they are not nearly as good as we thought. So that's why we want controlled clinical trials, and that's why we want all the groups to be studied, men and women, people of color, people of different ages. We'll hear more about that later, but just to say it takes time to do that. And if we speed things up, we're going to have less of that kind of information.